All right, so this month for the MEC Minute, we're going to kind of do a triad of topics here. We're going to talk about trauma triage, trauma hospitals, and helicopters. So this is probably going to turn out to be a fairly long conversation. I've put a lot of time into this because I want to make sure I cover those things that I think are important, and I really find it hard to talk about trauma triage, trauma hospitals, and helicopters separately. I think they all kind of commingle, so I put them together as a single topic. Why are we having this conversation? Well, in part, we're doing it now because Mount Carmel East becomes a level 2 trauma facility beginning August 8th, 2018. And the other reason is that we now have 3 air medical transport services, also known as HEMS or air medical, in central Ohio, and they are competing for business. So I felt that we should also talk about helicopters if we're going to talk about trauma and trauma triage. So what are we going to talk about? We're going to talk and review Ohio's trauma triage rules, just some basic understanding. I know you use them every day, but I just want to cover them again. I want to talk about trauma centers and trauma center designation and what it means. There's some confusion in terms of what a trauma center is versus what a Category 1 or Category 2 trauma is. So we'll talk about that. And then I also want to have a conversation a bit about utilization of helicopters, at least give my opinion of when helicopter use is appropriate or maybe inappropriate. So what we're not going to do today is talk or endorse any one trauma facility over another. We're going to talk about trauma facilities and how they are credentialed by the American College of Surgeons, which is the accrediting entity for trauma centers, and which what Ohio uses to designate trauma facilities. So this is a large national professional organization. They're in the business of designating and certifying trauma centers. It's not for us to decide if one trauma center is better than another, because American College of Surgeons applies the same standards to everybody. And we're not going to endorse any particular helicopter service. If you anticipate a need for using a helicopter in your service area, then you should have a conversation among yourselves and with your chief and other leaders to determine which helicopter service you're going to use, and make sure that your dispatching center has contact information available and on file. I want to talk a little bit about trauma triage. Again, it is a bit of a review. As part of our MEC Minute, there is reference to this COTS guideline, which is the Regional Trauma Triage and Transfer Guideline. It reviews the Ohio trauma triage categories or criteria, but also reviews some special topics related to Central Ohio, such as agreement between the trauma facilities over where pregnant patients should or shouldn't go, where pediatric patients should or shouldn't go, where hemophiliacs may go, and so on. So we'll talk a little bit about more of that in detail in a little bit. If you look at Ohio Revised Code, there is a definition of trauma or traumatic injury. So there are 2 standards that have to be met. So to qualify as a trauma or traumatic injury in terms of trauma triage and destination decisions, the first decision point is, does the injury represent a significant risk of loss of limb or loss of life, significant permanent disability, or significant permanent disfigurement. So that's the first step. The second step in deciding if the patient meets the trauma triage rule is if this injury was caused by blunt or penetrating trauma, if it was exposure to chemicals, radioactive energy, or electromagnetic energy, such as electrocution or thermal injuries and so on. Was the injury a result of drowning, suffocation, or strangulation? And finally, was it due to too much or too little heat, so thermal burns or frostbite injuries and so on. So those are the 2 basic criteria that have to be met in order for the trauma triage criteria to apply. If we look at the trauma triage criteria, it generally is broken down into physiologic and anatomic criteria. I've got them listed here. I know you're familiar with them. A third item that fits into the trauma triage criteria is cause of injury based upon vehicle telemetry data is consistent with high risk for injury. So if you receive some communication from OnStar or one of the other similar vehicle telemetry services that there is a significant injury or significant event that might result in injury, then there also is indication the patient would meet trauma triage criteria. So look first at the physiologic criteria having to do with GCS, LOC, whether or not there's a change in LOC with EMS present. Is the patient unable to localize pain? Do they have a respiratory rate that's less than 10 or over 29? Do you need to provide any ventilatory support such as BVM or CPAP or artificial airway such as an iGel or an endotracheal tube? Did you have to do something to relieve a pneumothorax? Was there or is the patient's pulse rate over 120 with evidence of hemorrhagic shock? So if the patient's walking around and anxious and their pulse rate's 120, that's a whole lot different than a patient who has a amputation, has blood all around their body part, and their pulse rate's over 120. One has an obvious evidence of blood loss. The other is more likely an anxiety response to the event. And then again, is systolic blood pressure less than 90, or if there's no radial pulse when you can feel a carotid pulse, sometimes you can do that much more quicker than actually getting a blood pressure. There are also anatomic criteria that have to do with whether or not there's penetrating injury to the head, neck, or the torso, whether there's any penetrating trauma proximal to the knee or the elbow with any evidence of neurovascular compromise. Is there injury to the head, neck, torso with any visible crush or any abdominal tenderness, any evidence of flail chest or pelvic fracture? Do they have any injury of extremities where there's an amputation proximal to the wrist or ankle, or where there's visible crush of the body part, where there's 2 or more long bones that are fractured, so femur or humeral fractures, and whether there's any evidence of neurovascular compromise with the extremity injury. Another anatomic criteria is if there's any signs or symptoms of spinal cord injury, if there's any evidence of second or third degree burns over more than 10% of the BSA, or if the burns involve the face, hands, feet, genitalia, or the airway. Or the last anatomic criteria is if there's an open skull fracture. So that's a quick review of the criteria, but that is for adults. If we're talking about the geriatric trauma criteria, and Ohio is fairly unique in that we have specific criteria for geriatric trauma, and this applies to patients who are 70 years of age and older. I've pointed out those criteria that are different from the adult criteria. So whereas the previous adult criteria had to do with the GCS of 13, in the geriatric population it's less than or equal to 14 with suspected or readily identifiable traumatic brain injury. If there's any fall from any height, including standing height with evidence of TBI or traumatic brain injury. If their systolic blood pressure is less than 100 rather than less than 90 for adults. If they have fracture of 1 or more proximal bones from long bones from an MVC, whereas for adults it's 2 or more. And then any geriatric patient that is a pedestrian struck, where then there's a need for trauma triage to a trauma facility. And a pedestrian struck is one of those few items that's currently listed in our trauma criteria that has to do with mechanism of injury other than the telemetry information from the vehicles. So one of the questions that comes up with geriatric trauma is how about the anticoagulated patient? And that can be a tough one. Anticoagulation is something that should be considered as part of your triage decisions, but if the patient has a minor head injury and they're anticoagulated and they do not meet the GCS requirements, then there's no absolute requirement that they be taken to a trauma facility. From the pediatric perspective, there are some changes to the criteria in that it now calls out evidence of poor perfusion or evidence of respiratory distress. So if that gestalt when you see the child is that they're in trouble because they're cyanotic or they're not breathing well, that's an automatic need to be taken to a trauma facility. And if the respiratory rate is less than 20 in infants or children under the age of 1, then they need to go to a trauma facility. So what I've got now is, this is an excerpt directly from the COTS document. It's in our protocol. It's got every item by bullet point. It's a little different format than what you might be used to seeing, because this actually has the bullet points rather than items being broken down into physiologic and anatomic assessments. In general, though, mechanism of injury may be considered as part of your destination decision, but it's not an absolute indicator for transfer to a trauma facility, with the exception of geriatric triage criteria, specifically say a pedestrian struck in an older patient. Those patients need to be taken to a trauma facility. I think we're all aware that there are exemptions to mandatory transport. So if you read the wording of the first paragraph, it says emergency EMS, emergency service personnel shall, and the key word there is shall, transport a trauma victim as defined in our previous conversation directly to an adult or pediatric trauma center unless one of the following exemptions apply. So one of them is it's medically necessary to transport the victim to another hospital for initial assessment and stabilization. So if you're far out and the trauma facility is not close by, but another facility is closer and the patient is unstable, it is appropriate and allowed that you take the trauma victim to a non-trauma facility for stabilization. Another criteria is if it's unsafe or inappropriate due to weather to try to drive to a trauma facility. We are all aware of episodes, we've all had personal experience where we have a victim of trauma. You can almost see a local hospital, but it takes you a good half hour to get there, and to try to get to a trauma facility would be even longer. So we go to the closest hospital we can get to in bad weather to get the patient stabilized and then transferred. There also is an exemption if transporting the victim to a trauma facility would cause a shortage of local emergency medical services resources. I think this is very apropos for our members who are outside of Franklin County, where to drive a patient to Columbus for a trauma facility or to a trauma facility would take that vehicle out of their service area for a long period of time and put a significant stress on the EMS service. In that circumstance, it is appropriate to take the patient to the local hospital. For those of you who are member or providers with a member agency where it's kind of a gray zone between do you go to a trauma facility versus do you go to a non-trauma facility based on distance, you need to have a conversation with your chief and with your peers. Another criteria or exemption is if the trauma facility simply can't take any more patients without a significant delay. So an example of this may be we have a major event in town where there are a large number of casualties, and there's no way that only the trauma facilities can provide care because they're going to be overwhelmed. That's a circumstance where we would take the patient to another non-trauma facility. And then finally, patients always have the rights of refusal. If the patient indicates before the transfer has been started that they do not want to go to a trauma facility and have a preference for a specific hospital, then EMS may take that patient to the patient's requested hospital or preferred hospital. But I would make sure that when you contact the receiving facility, you let them know that you're coming at the patient request. So based upon the COTS document that I've included in the handout that accompanies this video, there are some special considerations for Central Ohio regarding trauma and trauma transport. And these are basically 7 items that the Franklin County trauma facilities agreed to. And these are all considerations that you should keep in mind. So the first is that children under age 16 should be transported to Nationwide Children's. However, the second consideration is if a child is less than 16 but is pregnant, they should be taken to an adult hospital where they have obstetrical services available. Children's Hospital does not have obstetrical services available. Burn patients go to OSU Wexner for adults or to Nationwide Children's for children. People or patients with eye injuries or globe injuries should be taken to either Grant, Mount Carmel West, or Wexner. I think this will have to be modified when OSU comes online and Mount Carmel West stops being a trauma center. Have not heard yet regarding globe injuries going to Mount Carmel East. We essentially have the same ophthalmologists and the same maxillofacial trauma surgeons available. So I don't see it changing, or I see it changing to East but not West. But I'll give you an update on that when I find out. if you look at our protocol, we identify 2 facilities to receive victims of amputations. Now Grant has been added, so if you have a patient with an amputation or has a need for microvascular surgery, Grant or Riverside can receive these patients, as can Ohio State Wexner and Children's. In the instance regarding mass casualty events, there are specific surge plans in place which would override all the other considerations. And in that rare circumstance where you have a hemophiliac who is a victim of trauma, the preferred receiving hospitals for that patient would be Ohio State Wexner or Nationwide Children's. I want to talk a little bit about trauma centers and clear up some confusion about trauma centers. Category of trauma is not the same thing as level certification of a trauma center. So if a patient is a category 1 trauma, it does not mean they have to go to a level 1 trauma center. And if a patient is a category 2 trauma, it does not mean they should be going to a level 2 trauma center. Trauma center designation, like I mentioned earlier, is via the American College of Surgeons. They have a committee on trauma that performs the site visits and grants accreditation, whereas categories of trauma are used by hospitals to allocate resources on patient arrival. So less acutely injured patients may be categorized as a category 2, which means less resources will be available or identified for that patient on arrival in the resuscitation bay. So if we're talking more about trauma centers, they are certified by the American College of Surgeons Committee on Trauma. It's a very rigorous process every 3 years. And there are 4 levels of trauma facilities. Level 1 trauma centers are expected to manage the most severely injured. Level 2 trauma centers have essentially the same standard of care or provide the same standard of care with the same care expectations. However, some of the standards regarding supervision of surgical critical care are less, and these level 2 centers tend to have lower volumes and have no requirement for publishing research in recognized medical journals. Level 3 trauma facilities typically manage victims with expectation that they're going to transfer the more acutely injured out. And then level 4 centers are basically stabilization centers where patients can be initially assessed, stabilized, and then transferred on to a higher level of care, generally to a level 1 or a level 2 center. If we look at level 1 versus level 2, and we're talking about this because I know there's questions about, Mount Carmel East is going to be level 2, Riverside is level 2, but should we be taking certain types of patients to a level 1 center rather than a level 2 center? Well, if you look at the resource guide from the American College of Surgeons, there's an outlined section, highlighted section there right in the middle. It says the standards for the provision of clinical care to injured patients for level 1 and level 2 trauma centers are identical. In other words, injured patients are expected to be cared for in the same fashion at both locations, and both level 1 and level 2 verified trauma centers have shown they have that capability. For Central Ohio, the primary difference between a level 1 and a level 2 center has to do with patient volume and number of articles published. So level 1 generally is expected to treat or evaluate 1,250 patients per year and admit at least 240 patients a year with an injury severity score of over 15, meaning they have injuries of moderate to severe complexity. And level 1 centers are expected to publish 20 articles every 3 years, and those articles have to be identified as part of the credentialing or the site visits every 3 years. If you look at Ohio, or if you look at Mount Carmel East and Riverside and those other areas where there's a difference between level 1 and level 2 having to do with critical care oversight and so on, availability of microscopes for surgery and credentials of some of the subspecialists, Ohio or Riverside and Mount Carmel East have easily meet those requirements as well, which again basically makes patient volume and amount of articles published to be the big discriminators between level 1 and level 2 in Franklin County. Talking more now about categories of trauma. Categories of trauma, like I mentioned earlier, indicates the amount of hospital resources allocated to provide patient care on arrival. So the category 1 patients are severely injured. They tend to be the patients who meet one or more of the state trauma triage criteria. And then category 2 patients tend to be the less severely injured, and they tend to be the patients who have concerns regarding mechanism of injury that brings them to the trauma center. What I've got attached as an exhibit on this slide is an example of categories of trauma from the ACS manual that I showed a couple slides back. Some hospitals, I know Mount Carmel has a trauma consult service available as well. These patients are seen by the consult service when they have a need for admission or a trauma assessment, but they're not so severely injured that they meet need for a Category 1 or Category 2 assignment. Within the Mount Carmel system, typically these are patients who are evaluated at a non-trauma facility and then have a need for admission to a trauma facility and are transferred, but they don't need to have a trauma alert before they arrive. So the trauma service is notified on patient arrival. Patient or the residents come down, evaluate the patient, and the patient is admitted. So trauma consult is kind of a third option in terms of how we respond to trauma patients on arrival in the emergency department. I just want to mention level 3 trauma centers because there's been some talk that one or more hospitals in Franklin County are looking to become level 3 trauma centers. Level 3 trauma centers are a step below 1s and 2 in terms of what they are expected to manage. There's an expectation that the more critically injured patients will be transferred to a level 1 or level 2 center. And there is a group of patients that they can keep at their hospital and treat there. So trauma or level 3 trauma centers are generally meant to serve communities that do not have immediate access to level 1 or level 2 centers. Good examples are Genesis in Zanesville and then the hospital in Marietta. They are level 3 trauma facilities and do quite well and will periodically transfer patients to Columbus or Morgantown or Pittsburgh if there's a need for advanced trauma care. Just kind of comments on my own, I'm still trying to figure out what the role of a level 3 trauma center is in Central Ohio and Franklin County. I think that'll become more clear if we actually have a level 3 center open up in Franklin County. So the role of these level 3 trauma centers is yet to be determined. And I just have to wonder if we have level 1 and level 2 centers that are only minutes away from a level 3 center, what type of patients would we take to a level 3 center? And perhaps best patients for a level 3 center would be the Category 2 patients. Again, this is just my personal thought. I think it'll be more clear when a level 3 center opens, if it does, in the Columbus area. So what should we do? I think for us, we should follow the trauma triage rules and guidelines. And if the patient meets any of the criteria of the Ohio Trauma Triage Guidelines as published in Ohio Revised Code, then we should take the patient to the closest level 1 or level 2 trauma center based on travel time. So you have a better idea than I do in terms of how long it takes to get to one hospital versus another. If the patient meets criteria, they go to the closest facility. For those facilities that are not in Franklin County or not contiguous to Franklin County, where we have to look at transport times and stressing the system, then you have to weigh transport times versus what that transport time is going to do in terms of stressing your facility. Whether or not the patient is severely enough injured that need to be stabilized at a local facility and then transferred after stabilization is provided, or if weather is going to prevent you from getting to a trauma facility on a timely basis. I think this all requires some forethought and discussion ahead of time. So, please have these conversations with your peers and your chief. But for those agencies where ready access to a trauma facility is available, whether it's Ohio State, Riverside, Grant, or Mount Carmel East, go to the closest facility. Helicopters may also play a role in patient transport, and we're going to talk about that next. So how about helicopters? Well, there's been a policy statement out for a couple of years through the National Association of EMS Physicians as well as the American College of Emergency Physicians, and I've got it listed on this slide. EMS and healthcare systems should have and follow guidelines for helicopter utilization. And clinical benefit can be provided by shortening of time to delivery of definitive care. So if you can get them to the right place faster, helicopters should be considered. The helicopters may provide specialized medical expertise or equipment to patients before and or during transport. When the helicopters first started back in the 80s, that was particularly true. I think for many of our EMS agencies and most, if not all, of our MEC member agencies, we have the same skills and capabilities as the flight crew. Unless the helicopter happens to have blood on hand. And I'm not sure if they're going to be carrying, all of them carry blood or not. And then helicopters do provide transport to patients who don't have any ready access to other means. So if it's deer season, the patient falls out of the deer stand and they're half a mile from where you can get with your truck, then maybe a helicopter is a better means of getting the patient off scene into a facility. So they do provide benefit there. In terms of MEC EMS on our protocol, we don't have a protocol for helicopters. Perhaps we should have one. If there's a big consensus that we should develop one, we can put it in the protocol for 2019. But currently, we have no protocol. We should do what's in the best interest of the patient. Sometimes helicopter transport is appropriate, but I think we have to consider a lot of things before we make the decision about using a helicopter. Helicopters are expensive and they can be risky. I think we'll all see from time to time reports of an air medical helicopter going down either because of weather or mechanical failure. And then there's some current thought, although I'm going to talk to you in a couple slides about a different thought, that if you can have access to a trauma facility by ground in less than 30 minutes, then the utility of a helicopter is probably just not there. So if you're within 30 minutes of a trauma facility, ground transport may be cost effective and more timely than a helicopter. I just have here just a summary of a article published from Arizona. They looked at patient transports within the state of Arizona. They had 5,200 patients who were as part of the trauma registry and database during the study period. 18.9% of those patients were transported by helicopter. And of those patients who were transported by helicopter, just under 30% of them were discharged from the ED, meaning they were transported by helicopter, assessed in the emergency department, and discharged home from the emergency department. If they looked at all patients transported by helicopter, 55% of patients brought in by helicopter were discharged within 24 hours. And there was no mortality difference between patients brought to the hospital by EMS versus helicopter, meaning there was no advantage in terms of lives saved by helicopter transfer versus ground transfer. And in this Arizona study, the average cost per helicopter transport was $18,000 per visit. Which all this prompts me to think, do we use the helicopters as often as we should, or do we overutilize? I think one side comment for me is we over-triage trauma patients anyway, meaning we tend to take patients to trauma facilities more often than is really needed, but the accepted over-triage rate is around 30% anyway. So if we don't we don't bring too many patients, or if we get too conservative our triage criteria, we may miss patients who really need the service. So the point that I'm trying to make, although I'm doing it poorly, is this 27% discharge rate from the ED is not a whole lot different than a 30% over triage rate for trauma victims. So perhaps you can make an argument that these patients were appropriately transferred by helicopter. Another series of articles, two of them from Pennsylvania, looked at helicopter transfers and whether or not there was benefit, and is there a way we could possibly do or develop a triage tool that would give us some assistance in determining who's best transported by a helicopter. So one article looked at patients within this trauma registry, and they identified patients with an abnormal respiratory rate or a GCS less than 8, less than or equal to 8, or any evidence of a hemothorax or pneumothorax as definitely benefiting from helicopter EMS, even when ground EMS was available. They also looked at travel times, and is there a break point where travel time from the scene to the hospital may make a difference in terms of determining if a helicopter is cost effective and appropriate. And this study, they found that if during peak hours of traffic, so when the freeways are congested, a travel distance of more than 6.5 miles to a trauma facility would make a helicopter cost effective. And during off-peak hours when traffic was not bad, if the travel time was over 7.9 or 8 miles, that a helicopter is cost effective and appropriate. So this is decidedly different than my previous suggestion that maybe 30-minute difference is necessary. So the bottom line is there's some research out there, and some of the more recent research out there, suggesting that helicopters can be a timely service and an appropriate service even for fairly short travel times. Specifically looking at the HEMS or helicopter triage rule, this is what came out of one of those articles. They looked at 2 million trauma cases in developing the rules, and then retrospectively looked back at 200,000 trauma cases to apply the rule and determine if it could be used to identify patients that would benefit from helicopter transport. So it's a point system, and they looked at Glasgow Coma Scale, respiratory rate, any evidence of chest wall fracture, which would be a flail segment or anything like that. Any patient who had a suspected hemothorax or pneumothorax based on breath sounds and respiratory distress. Any patient who was paralyzed, any patient who had multi-system trauma, meaning they had 3 or more anatomic body parts that were affected, or if the patient had any one item from physiologic criteria plus any one item from anatomic, then they would get points. So there's a scoring system that's there, and if any patient had a score of 2 points or more, then helicopter transport would be beneficial based on this study. What the confusing part for me is, how much time do you expect your guys to take to perform this assessment and then get the helicopter in the air? Most of our practice is if we have a high-risk event, we have the helicopter en route before the crew even arrives. So, it's something to consider. I'm not sure if it's really ready for prime time, but I'm trying to bring up some items just to give you something to think about. So in terms of helicopters, I kind of have 2 questions and 2 comments. The questions are, first, answer in your head, does the patient meet Ohio's definition for trauma or traumatic injury? And if the answer is yes, then will the helicopter significantly shorten transport time? And if the answer in my mind is yes, then I think there's benefit to using the helicopter. But you have to also consider my 2 comments. The primary benefit of helicopters is speed. So if the helicopter is not on the ground ready to take the patient, then any potential benefit of speed is lost. So if we can't load and go that helicopter, then the advantage of speed is lost, and the patient is probably better off going by ground. So that's something to consider. The other thing is, as part of my comments, is we do not endorse any particular service. So if you have a potential need for a helicopter in your jurisdiction, I suggest you have that conversation with your chief and your leadership to decide when and how you're going to access helicopters. So the bottom line, this is kind of my summary slide. I'm almost done. In summary, patients who meet Ohio trauma triage guidelines should be transported to the closest level 1 or level 2 trauma center. And we define closest as travel time or transport time, unless there's a 1 or more of the permitted exclusions are met, which has to do with need for stabilization, bad weather, patient request, undue stress on the system, and so on. For non-Franklin County MEC EMS members, if the difference in travel time to a trauma center versus to a local ED is not great, then I would advocate for transporting the patient to the trauma center. So if we're talking, a couple minutes difference either way, again, you get to decide, if that difference is significant based on your jurisdiction's policies. If you're a non-Franklin County MEC EMS member and the closest hospital is a non-trauma center and one or more of the allowed 5 exemptions exist, then transport the patient to the closest hospital. I think for most of our member agencies who do not have immediate access or close access to a trauma hospital, it's going to be stress on the system or need for stabilization as the driving forces for patients to be taken to a non-trauma facility, and that is perfectly appropriate and accepted based on the Ohio Revised Code. And then use a helicopter if it makes sense and will make a difference in the patient outcome. So that's it. I appreciate your time. If you have any questions, please post them on Workplace or send me an email. If you send me an email, I can guarantee I will share it on Workplace for everybody to review. Thank you.